Friday. So we're going to start this morning with introductions, and I'm going to start going around the table here. Nancy Jensen with the Washington Health Alliance.
And I'm Dan Lessler at the Healthcare Authority, and I'm normally a standing member of the committee today. I'm actually sitting in on behalf of Dorothy Teeter, who sends her regrets. She had a death in the family and had a service today back.
Laura Pennington, the Healthcare Authority.
Good morning, everybody. John Espinola with Primera.
Mary Kay O'Neill from Coordinated Care. Ann Christian with the Community Mental Health Council. Cheryl Strange with the SEIU Healthcare Health Benefits Trust.
Courtney Smith, Spokane Regional Health District.
Patrick Persons, Spokane Valley Community Health.
Kathy Rose, Department of Health.
Jonathan Sugar from Police Health.
Gordon Volk, Miami, Washington, Board of Directors.
Scott Ramsey from the Fred Hutchinson Cancer Center.
Marguerite Rowe, Public Health in Dallas King County.
Grace Blackmore, Virginia Mason, and the Health Technology Chronicle.
Ann Hirsch, Seattle University. Jessica Cromer, Mayor Group Washington.
Rick Rubin with One Health Point.
Cara Panic with DSHS Virgin Fire.
Susie Dave with Washington Health Alliance.
And we also have 3 committee members who are on the phone: Julie McDonald, Dale Reisner, Sue Geets. We need to pick up a little bit, we're told. Okay, so, and we also have 56 webinar participants and some guests in the room, so we want to welcome everyone. We'll start with just a few housekeeping items. You see Wi-Fi access there. There's no formal break. Please take a break as needed. We're a little cozier here this morning in this room. That'll be great for a conversation. Please silence your electronics so that we can all be present together. And because we're on an overhead mic today, anything that we do to jiggle papers or move things around is picked up on the webinar. If we could kind of keep that to a minimum, it would be great. Or if we do, quickly push back on the table so that we don't have that disruption on the webinar. I want to remind everyone that this is a public process. We're all very committed to making this very transparent. There'll be many public comment opportunities, both today. All documents, you know, are on the Healthier Washington website, and comments are welcome to the Healthcare Authority at any time. And then our work for the day is really threefold. We're going to look at the starter set of performance measures, the decisions we made in December of 2014, and give an update on the implementation process for both measures and reporting. We're going to consider measures that have some specific implementation challenges and provide advice. And finally, recommend to the HCA one new topic area that an ad hoc work group should tackle in 2015 for measurement reporting next year. And with that, I'm going to turn the time over and the forward clicker over to Susie Day, who will take us through the next part.
Good morning, everyone. I'm going to stand up so it's a little easier to see me and hear me. And I want to welcome you to this morning's meeting. And as Nancy said, today we really have 3 objectives: is to refresh, advise, and then on the final agenda item, we'll be asking for a decision for action from the group. So this is the refresh part. So to remind you, it's been 6 months since we last met, and I just want to remind you what decisions we made so that we can kind of get on a level playing field and move from there. So if you remember, we had 3 work groups. We went through a 6-month process. We selected 52 measures. The list on the screen is really a list of all of the high priority topics that the work group thought were important and considered in their process of recommending a set of 52 measures. All of them are covered in the measure set, with the exception of the ones that are highlighted in red up there. And I would just tell you that later today our last agenda item is really, the action item is to select one area, and a couple of these are on the short list of recommendations from the Healthcare Authority. So behavioral health, cost and utilization, safety, accident prevention, care coordination, functional status, those were areas that we thought were important when we went through our process, but at the time we didn't select and recommend measures because there were no good nationally vetted measures, or because we didn't have a readily available data source in Washington, or because of both of those things. So what this shouldn't look unfamiliar to you, but this is the contextual framework that we put together as we were making our decisions in 2014. And really the purpose of the slide is just to say that we recognize that measurement and public reporting transparency is a very important tool. It's an essential tool, but it's really just one part of the process in terms of improvement over time. And so that we recognize that community transformation and practice transformation are both really critical to actually making headway in any of this, but that the measures and the reporting of results is really an important foundational tool for that activity. When we our culminating measure set of 52 included some population measures. There were actually 5 of these. And these are really, they focus on prevalence. That we consider them population measures because they're based on data and or the size of N, meaning the what we think we're actually able to measure and how much data there will be. That results are possible only for the state and possibly for counties and ACHs, which are accountable communities of health, or groupings of counties. For those of you who don't know what an ACH is, there are 39 counties and there are 9 ACHs, and each county falls within one of those ACHs. There are a number of clinical measures that apply to clinical settings, and in fact, this makes up the bulk of the measure set. There are actually 44 measures that focus on clinical processes based on data availability. We believe we have the opportunity to report results at the health plan level, or medical group level, and or hospital level, and many, but not all. We believe we're also going to try and have results available by county, ACH, and state. And then finally, we had 3 cost measures on the list, and again, this is a very, in my opinion, a very limited list of cost measures. And it was really based on very limited pricing data available in the state today to do measurement of pricing. But we know this year, and not too terribly long ago, the governor signed legislation to create a state all-payer claims database, and we believe that it's going to take some time to get that up and running. And I think realistically, we're looking at somewhere in 2016 to begin to see results generating from the new state-mandated all-payer claims database, which will give us access to pricing data. So to continue with our status report of where we are, I realized in preparing this that there's actually an error on this slide. There are actually 12 organizations that will be submitting results to the Alliance, and the Alliance will be coordinating all of the public reporting effort on behalf of the state. We signed a contract with the state at the end of May to take this lead role. The organization that is missing from the slide is Delta Dental, and if you're on the phone, Glenn, I apologize that I left it off. That was my oversight. But the organizations beyond Delta Dental, of course, are the Alliance, the State Department of Health, the SHS, the Healthcare Authority, the State Hospital Association, and the 6 commercial health plans. We've begun meeting with all of these organizations. We've had a variety of meetings between the Alliance and these organizations. The meeting with the commercial health plans is scheduled for July 8th. So that we just were unable to get that done before this meeting because it involved coordinating schedules with more people. We don't want to meet with health plans in a one-off basis. We want to meet with them all at the same time so that we don't have these serial conversations, because standardization is super important in this process. John?
Sorry.
That's okay.
Can you comment on how we will get information from the Medicare carriers?
Medicare.
Medicare intermediaries, MAPD plans, as well as Medicaid managed care organizations?
Yes, let me start with Medicaid. talking to both DSHS and the State Healthcare Authority, who will be working together. We've had a meeting with Mark Lance and Dave Mancuso, and they are working together to produce health plan level results by managed care organization for there are 6 in the state, but only 5 in 2014. So there will be results for the 5 at the health plan level, and we're working directly through the Healthcare Authority and DSHS to generate those results. Delta Dental will be working with us on the oral health measure, which we're going to talk about in some detail a little bit later on, that particular measure. On Medicare, for this, we don't have access to very robust Medicare data in the state. We've got...
we have plans, though.
We have plans that do, but not any real solid fee-for-service Medicare data access to that. So there are a number of Medicare, there's Medicare results in the hospital measures that are reported through Hospital Compare, but for a lot of the HEDIS measures, for this first year, we won't be looking at Medicare. We're looking at Medicaid and commercial.
Okay.
And something we
I
can
just think
work on over time.
Yeah, we probably should, because
The
from
huge population.
a prevalence and utilization perspective, they're probably getting, other than the duals and on the Medicaid side, they're probably getting the most health care. So that population will give us data. So.
Agreed.
So one thing we are working on with CMS is we're going to submit a request for access to Medicare data. We're actually drilling this down to the patient level, processing a little bit at a time because we want that patient identifiable data point to be able to look at it by county level. It has to go through a HIPAA review process, so we will be doing that.
Okay. And just keep in mind that several of the health plans up there
have Medicare.
Carry maybe between them 75 to 100,000 Medicare lives.
Right. Thank you.
Yeah, I just wanted to underscore the importance of the timing of this. We have our contracts with Medicaid managed care plans include quality components. We received our first draft of quality goals for 2016. They're not in harmony with these goals. So the contracts today are being written with the quality metrics. Medicaid managed care plans that aren't aligned with our goals through 2016. It's really important to get those Medicaid managed care plans aligned because that's the timeline that they're working under.
You want to comment?
Yeah, I mean, I totally agree. I'm sorry.
Having a hard time hearing.
So I totally agree. I think part of the issue here relates just to the timing of the contracting cycle with the availability of the core measure set, and so we do need to align those.
So yes.
Just one, on the commercial health plan list, do you want to include every carrier on the exchange?
If there are others that we're missing, and I don't know, maybe you can talk with me offline. We were sort of trying to hit the big ones in the state, and we know that these 6 are the big ones. There's also Kaiser, which is very small population in the state, even though it's one of the insureds for PEP. Thank you.
These guys are getting big.
Yeah.
We have over 30,000 on the exchange.
Yeah. For coordinated care.
We have an exchange plan. Really? Okay.
Okay, I'll talk with you offline. Thank you. That's good insight.
Yeah.
Okay.
Especially because
So I'm going to sort of jump in and start talking to you about a status report for each of the 52 measures. And the attachment A is a good resource for that. And then when we talk about the health plan metrics, there's a single page attachment that says state common measure set, health plan level results. So before I start, what I'm going to just say is that there are a lot of moving parts here. There are 12 organizations submitting results on 52 measures, and there are multiple units of analysis. So I can guarantee you that we are not going to get this 100% right this year. We're not going to figure out every last organization that should be included, that this is, I very much appreciate the input, but I don't want to set the expectation that we're going to get this 100% right. It's a fairly complex process. There are a lot of moving parts. Much of it is new for some organizations. And so, I'll just ask you to kind of bear with us as we move through it. So, detailed planning is now ongoing. As I mentioned, the Alliance, we only signed our contract at the end of May. So during June, we have begun the process of meeting with the various entities that will be submitting data in order to talk with them about how to submit those data extracts. The data submissions are due to the Alliance. The final data submissions are due in early September, but there will be test data submitted mid-summer so that we can sort of try and work out the problem. We intend to have for those measures where the unit of analysis is the medical group, we intend to have medical group results for 14 of the 39 counties this year. We will not have all 39 counties. It takes time to build out these provider rosters. But in those 14 counties, we will have results for groups of 4 or more providers that have at least 100 things, whatever the measure is, in the denominator. So that's the threshold for public reporting. We know right now that we will probably have results for about 140 medical groups and about 600 clinics in those 14 counties. That's sort of the early read from the data. For hospitals, which I forgot to put on the slide, we're working with the State Hospital Association for a lot of these, and there we're going to be using minimum denominator of 30, which is consistent with what is on hospital compare. The first measure set report will be available during fourth quarter of this year. We expect to have many of the results available on the Alliance's Community Checkup website. And then there will also be a couple, actually, of different written reports. And again, just to remind people that there's these multiple units of analysis that vary by measure. So state, county, ACH, medical group, hospital, health plan. A lot of moving parts here. So to begin, good news first. There are 16 measures on track. This is on pages 2 and 3 of the legal size handout. Starting there on page 2. 16 measures are on track. We have no known concerns about implementation. What is impressive? Yeah, we're getting there. So this is based on meetings that we've been able to have to date. So because there are some things, like for example, I'm going to talk in a minute about health plan level results. I don't know that it's not on track. We just haven't had our meeting yet, so I don't want to, send up any false alarms about anything. But these I know about because we've talked with people about it. We're in pretty good shape. There are 11 measures that we believe are on track, but with uncertainty about commercial health plan reporting, as well as some other units of analysis. And these are on page 3 and 4. Now, this is a good opportunity to show you this one-page handout. I want to talk to you about health plan level results. This is probably the most complicated thing we're going to talk about this morning, just because there's a lot of information. So if you look at the side of the sheet that only has 9 measures listed, last December, when we finalized the report and approved it, these 9 measures, we knew last December that the data would have to come from health plans because they're the only ones that actually have the data. And so that's not new. And the only reason I'm not entirely sure about it, these 9 measures, is because we haven't had our meeting with the health plans yet. There are 7 of them. The first 7 are all NCQA HEDIS measures. The last 2, primary care prevention and the psych inpatient readmission, we're going to talk about later. So just kind of set those 2 aside at the bottom. We're going to talk about each one individually and have a specific recommendation around those. On the back side of this sheet are another 18 measures that, again, last December, we agreed through our process, lots of work group input, public comment period, you all made the decision that among other things, we would include health plan level reporting for these 18 measures. Again, all NCQA HEDIS measures. What health plan level reporting means is that we will have a report that says group health has these rates on these measures. Primera has these rates on these measures, and so on. That's what health plan level reporting means. As the Alliance has gotten further into this and has had a chance to kind of think it through a little bit, we've come to realize that we think it would be far superior to get these results generated and submitted to the Alliance for reporting by the health plans themselves. And there's a reason for that. We believe we can generate results on these measures using the data warehouse that we have. We've got 4 million covered lives. But we also know that the results we generate for health plans will be incomplete because we're not working with a full book of business for the health plans. The health plans all measure these things. They're NCQA HEDIS metrics. We're looking at calendar year 2014 for results. All the health plans, with the exception of one, already submits these results to NCQA, and it's part of their accreditation process. And Regents is in the process of becoming accredited, and I know that they're measuring these results as well. So what we're going to be talking to the health plans about on July 8th, and I've already told them all of this, is that we want them to submit to us numerators and denominators for all of these measures, so that what we publicly report in the state of Washington is calculated on their book of business, and it's consistent with what's reported to NCQA. We don't want different results publicly reported. So that's our plan around health plan measures, and it's just important for you to understand it. I'm going to ask you a question about this in a minute or two. But just to finish on this slide, there's a couple of other measures that are measured through BRPIS and CRAM survey data, where we just don't know yet what the unit of analysis is going to be, because we don't, the N we know we can do it at a state level, we just don't know if we're going to have results for every county because the N may be too small for some of these things. So that is sort of a TBD, the small N issue, and the health plan issue will hopefully be resolved by no later than July 8th. So are there questions just on this part so far?
Thanks, Susie. I'm curious about your thinking about counties with a small N. Would you be looking at trying to capture that data across the state and simply reporting that it's too small an N to identify in given counties? Or are you talking about not utilizing the measure?
Oh, no. We would utilize the measure, and we would report it at the most granular level we are able to. So ACHs give us an opportunity to combine data for counties that may make its reporting more possible, and actually will be useful to ACHs who are accountable communities of health, who are, formulating these efforts in their own communities to really focus on improvement processes collaboratively across counties. Kathy?
Yeah, I can just comment that we are increasing our sample size for the BRPIS survey in hopes to get estimates for every county. And what we've done in the past for the really small counties is we usually just roll a few years together, for the small counties. So, we would have estimates for small counties, but it would cover multiple years right now. But moving forward, we hope to have yearly estimates by county.
So we're going to get it as granular as we can. What is supported by the data? We're at the Alliance. Those of you who've been watching us over the years, we're very careful about not reporting data publicly that reflects a really small N. We have standards that we abide by, and when we don't have results, whether it's for, there's going to be a lot of medical groups that don't meet that 100 threshold, and we have an asterisk there, and we footnote it, and it basically just says there's not enough data to publicly report results for this entity, or, that's not exactly the wording, but it's something to that effect. John?
Susie, for the 18 or 16 on the back of your handout, would those are you gathering data with an identical methodology to what the plans are reporting in NCQA?
Well,
hybrid measure? Because you list claims here, I'm sure a lot of these are hybrid.
There are hybrids on this side,
Okay.
for sure.
Okay.
You know,
Because if we only get part of it, we end up with discrepancies in what you said.
that's part of what we're going to talk about on July 8th, which
yeah.
is why all the plans need to be in the room,
Yeah.
so we come to agreement about what people are reporting.
Yeah, I don't think we want to end up in a situation where we're creating confusion and maybe trying to act as a surrogate or substitute for already existing standard methodologies
I
within
completely agree, and the Alliance does not, nor does the state, I believe, have the wherewithal to, we're not auditing. I mean, that's really the reason why I believe it's important to report exactly what was reported to NCQA on HEDIS, so that we're entirely consistent and we're not second-guessing any of that. Yeah. So before, let's see, I think so I've covered this. These are the 18 measures. So before we leave this and get into the challenging topics, what I would like to do is just get a little bit of advice from the group. And some of you might sort of accuse me of looking for trouble where it doesn't exist. But I like to, I don't get to talk to you folks again until October, and a lot is going to happen between now and then. So I don't have any reason to believe that this will be true, but if there were any of the commercial health plans who pushed back and decided that they didn't want to participate in submitting results for public reporting, my question for you is, what advice do you have for me and for the Alliance and for Dan and Dorothy at the Healthcare Authority about how we should approach that situation?
We approached this before with the Alliance and the community health checkup. There must be those that didn't want that either.
Right. I'll give you two answers to that. One is, over time, we influence, cajole, pester, so we bring people along. When, in those few instances, when we haven't been successful at that, we just call it out publicly.
Would those apply in this situation? I mean, just the same kind of process, only a little different.
Well, the problem now is that the time frame is very compressed. You know,
yeah,
it's June 26th. Final data is submitted to the Alliance by September 1. It's summertime, you know, which makes things all a little bit more complicated to do things in a short time frame. So our timeline for pestering and cajoling is not as long as it sometimes is. I realize this is a weird question, but this is the time to ask, because I won't have another opportunity. Jonathan.
So in some of the previous iterations of this, plans have actually had to do some work in order to comply. So, you know, having resources and things like that could potentially be a reasonable explanation. But as I understand it, all the plans you're going to be talking to, you believe, have the data available. So the choice not to participate would not be based probably on capacity, resources, availability data. Is that correct?
I believe so.
Or it could be resources. I mean, that's always a
time
you add to the game.
So, but if you're asking for numerators and denominators, or something that's already been reported as numerators and denominators, my conclusion would be the resource requirement for that would be modest at best and likely minimal. So what I would say is, if you call them out, I think it should be clear. Plan refuses to provide data, which is different from plan did not provide. And I think that, and one of the reasons I'm suggesting some language is that should be potentially part of whatever the language is tied up on should be part of the discussion. So the decision about resource utilization, whether it's going to take an analyst a half a day or a programmer a week, needs to be balanced with what the consequence is. And frankly, if the consequence is data not available or NA or something like that, it's a lot different than plan refusing to provide data.
there's also a little bit of a, I mean, this may sound very straightforward. If the request is every plan that's NCQA accredited is required to produce the HEDIS measures last reported to NCQA, if that's the data point definition, then it's not quite as simple as pressing a button, but that's pretty straightforward. If there's any other data point definition, like current internal measure of HEDIS-like measures without the HEDIS denominator continuity restriction, now we're getting into work. I mean, so part of it is knowing what you're asking different systems to do because you understand their system. So so if it's what did you last report to NCQA, and you understand what the limitations of that data is, both from a population and a time frame perspective, and that's okay because that's how we're getting started, we can do that. But if you're looking for something more current, more comprehensive, then it's a project. It's a real resource requirement. So.
The whole purpose of this initiative is transparency. So I think being transparent about who participates and doesn't is probably the best you can do. I would be concerned about sort of overly harsh language, because there are human beings in organizations, and when somebody screams at you, you tend to respond, and that can poison the well for future collaboration. I think you're better off if somebody doesn't participate for whatever reason, noting in a fairly objective way, no information from this organization. And if you can't compel, then I think what you described earlier, the techniques the Alliance has used for a lot of years, you are cajoling, and then ultimately you're providing transparency into who does what and who doesn't. That seems to be, it's not the first time you're doing it. I think you want to preserve the fact that some strange thing happens, and that doesn't mean that somebody is being a bad actor, and preserve the opportunity to work constructively with them for the next time around.
Scott?
Slightly tangential question, but will you, for the commercial plans, will you be getting the self-insured data for their self-insured?
That again is a question that we're going to talk about on July 8th, so that we do it the same way. So I don't want to presuppose answers to the very questions that we're going to talk about on July 8th, but the thing that Mary Kay's talking about, that question, or the specifics around implementation, and my only requirement is not necessarily, it's that I want to be consistent with what's reported to NCQA, and I want to do it in a standardized way across all 6 plans. And then there are some areas that we've got to figure out, and that's a great example of one.
So on that note, I mean, if it does come to a point where you have trouble getting the data, you could go to the larger self-insured clients like the Boeings and ask them to request to have that data released.
Yes, but we don't really have time to do that in the short time frame that we have. In the longer run, we might be able to do that. Right.
This is not specifically to the plans, but in a general sense, I think if people are providing data, we need to make sure we're listening as to why.
Yeah, I think that's really important.
My concern is that one of the reasons people may not want to provide data is because of problems with the measures themselves. And it may be less true with HEDIS, although I'm not sure. But as we've dug in detail in some of these measures at our own institution, we've found that the measures are not perfect. A lot of these, they've gone through various filters, but they haven't necessarily been validated in practice as a benchmarking tool. So if you're getting that feedback, and you've responded before, but as you're getting that feedback, make sure we understand.
Yeah, Patrick. That's good. Thank you.
The first step is having good, transparent, publicly available data. The second step is having good, transparent, publicly available data that's used by purchasers to make decisions. So after this is finalized and you get a good sense of who did participate, and I think starting to flesh out the answer to the question of how are you making this meaningful and relevant to purchasers, what kind of campaigns can occur that go out to those that are purchasing the commercial products that say not all health plans are equal. Here's some resources you can use to inform your decision. Who's going to cover your employees and who can really improve their health?
Good. Thank you. This is all great advice, and I really appreciate it. What I would say is that the measures that were selected on the, you can see them on the one-page handout. If you take off the oral health and psych inpatient ones, set those aside for a minute. We're going to get there in a second. All the rest of these measures are measures that have been in use through HEDIS for quite some time. They're very well nationally vetted. There's nothing new here. They're in common use, not just by NCQA, but really in organizations all across the country for a variety of purposes. And I think that that's a really important point, because we're not coming out of the gate here with some new stuff apart from the oral health and psych. So with that, I think, yes, one last comment?
Just one quick question. You mentioned about the data, the database and usage and so on in the past, but I'm a little concerned about behavioral health issues, because as you know, the insurance parity regulations are fairly recent. And in fact, in the state of Washington, many of the providers still haven't implemented the parity provision. So I'm kind of worried about how you can integrate good data in the behavioral health arena with this. I think we need to asterisk or do something to indicate that the database and the broad perspective on the health care for mental issues really lacks on integrity.
Yeah. Okay. Thank you. Okay. So with that, we're going to move on to the sort of what I would consider some 5 of the measures which are proving to be just need a little bit more work. The first 2, I'm hoping we can make a decision about today. The 5 measures are, just to give you an overview, is oral health and 30-day psychiatric hospital readmission, and then the 3 healthcare spending measures is what we'll wrap up with. I do have a kind of a hot off the press handout, which I apologize to the committee members on the phone. We will make this available to you, but we'll try and kind of walk through it. So I'm going to take each of these 3 areas separately. The first one is oral health. So this is a measure that was NQF endorsed at the time that we selected it last December. In March of 2015, the measure, NQF pulled its endorsement of the measure. Glenn Pluckett from the Washington Dental Service Foundation happened to be at a conference recently where he actually met the man at the University of Minnesota that created this measure. So Glenn was really helpful in connecting me to him, and Glenn and I got on the phone, and I think Glenn is probably on the phone today via webinar. We got on the phone with, I think his name's Dr. Denard, Amos was his first name, to chat with him about it. And I wanted to know why NQF pulled their endorsement, and basically it was because he was unable to provide reliability and validity data in support of the measure when it came up for kind of renewal, and so NQF pulled the endorsement. When I asked him if he could provide the detailed measure specifications so that we could work on it, he was unable to really do that. So Glenn offered to draft some measure specifications, which he did, and I would like to publicly thank him for doing that work. We went at this believing that it was, a relatively straightforward measure to program. That was sort of our starting premise, and that we would look to the following for results. Delta Dental has already committed to producing the Medicaid results, and that we would look to the commercial health plans to program the measure and provide data on the commercially insured population. Originally, we thought we would be able to report at the state and health plan level and maybe at the ACH county level. So we have a number of concerns. Obviously, we knew this was a new measure when we approved it, but we did take some chances with the measure set. But there really is no real measure steward, and there really were no formally approved measure specifications locations that we could identify. And I took Glenn's draft of the measure specs and I submitted them to 3 of the commercial health plans, just people I know, and I said, what do you think? Is this, you know, how hard is this going to be to do? Do the measure specs look good to you? And on the handout that I sent around, really, you know, there are a number of cogent arguments for why we probably should table this measure this year for the commercially insured population. I myself am convinced. The draft measure speaks to using a CPT code that has only been approved for use starting in January 1, 2015. So it will be impossible to produce results for calendar year 2014. There are still a number of questions and issues related to the measure specification. I mean, I think Glenn did a great job of beginning the process of putting some detail around this, but I also think it's true that we haven't done enough to really vet the measure with the appropriate communities, meaning the health plans as well as the provider community. And so and you can read some of the other issues here, but for those reasons, I think that the health plans would recommend, and I think I agree with it, that we proceed with measuring this on the Medicaid population. And I've already heard from Dave and Barb Lance, not Dave and Barb Lance, Delta Dental, that they're willing to kind of test this out. We ought to test it and see how it looks. And we can make a decision, you know, after we get a good look at the data about public reporting, but that we don't ask the commercial health plans to try and program this for measurement this year. So with that, I will open it up for discussion.
Well, I'm one of the health plans, and I recommend it. I would greatly appreciate that. It's new. This is something that will take extra work. It's all the same issues that you described, so I think, not from group health, but this would be kind of challenging. We've actually tried to integrate this in the workflow as a pilot a few years ago. It would take a bit of work, plus getting everybody educated about, you know, doing it. So I think if you're already concerned about health plans not wanting to participate, this could put people a little bit over, and I don't think there's a good reason to proceed this quickly on this matter.
Other comments?
Are you asking the group to endorse your recommendation formally, or just?
Yeah, ultimately it'll be the decision of the healthcare authority, but this body advises them, and so yeah.
I want us to vote. We should probably vote.
Yeah.
Sure. I mean, I think I know how the vote's going to turn out. But it sounds like the sense of the group, based on the conversation, is to not put this one on the table.
I think the standard of a validated measure of steward is a pretty great standard to enforce.
The other piece I appreciate about this is that it does give us an opportunity to explore potential measures in a very thoughtful way that engages the plants over time. Coming from public health, I realize nothing ever occurs as fast as you want. And with these measures, I think the evolution makes sense to table it this year and then move it forward.
So, but I think I would like a little bit of clarity. So what we are recommending here, though, is that this measure is put aside for the commercial plans this year, but the work with Medicaid dental is still going forward?
Yes, well, what I would say is that we will run the measure, and then we need to sit down, take a look at what it looks like. And I mean, I think our goal should be that we can publicly report results on the Medicaid population, whether it's for the state as a whole or at an HEH level, for example, but that we give it a good go. You know, let's try and make it work.
Yeah, I just wanted to make sure we had that understanding here. Thank you.
Are you looking for a formal motion?
Sure. So moved. Is there a second?
Second.
Sure. All those in favor, say aye.
Aye.
Opposed, same sign. All right.
Great.
Thanks.
Thank you. You just made my life a little bit easier. And that's what it's all about, isn't it? No. Okay, so then the next challenging measure is the 30-day site hospital readmission measure. This was medication was developed by Dave Mancuso at DSHS. It is we knew it when we approved it. It's a homegrown measure. If you don't remember, what I would say is there was a lot of feeling around inclusion of this measure. It was important to include. But I will say it is not a simple measure to program. We included the measure specifications in your packet. I believe Dave has done some testing of this measure on Medicaid data. The commercial plans have never worked with this measure at all. So I believe we do have a commitment in place to produce results for the Medicaid population. But again, it's new for the commercial plans. And really what it means is that we would have to program and test and produce data for this metric in a very short period of time. I'm concerned that we won't have sufficient confidence that we're implementing it in a standard way across 6 plans. The measure we haven't had an opportunity to really vet this measure thoroughly with the commercial plans. Dave Mancuso is scheduled to come to our July 8th meeting and talk about it, but as I reached out to the plans prior to this meeting, the 3 commercials, for input, the recommendation here is really the same as the oral health measure, that we proceed with testing this measure for public reporting on the Medicaid population, and that we table it just for 2015 for the commercially insured population, and we use the next 6 to 8 months to really do the vetting that we need to do and kind of work through it. Comment?
Well, I don't comment, just a question. What's the basis for the 30-day issue? I mean, where did that 30-day thing come from?
That's a great question. So what Dave Mancuso did is he took NCQA's 30-day all-cause hospital readmission measure, which is a HEDIS nationally vetted measure, and he created a variation of that to look just at inpatient psychiatric readmission. And so 30 days is, I would say, sort of a common way to look at hospital readmission. So that's where it came from.
Yeah, part of the reason I asked that question, the 14-day stipulations on some of the admissions for inpatient, and I'm a little troubled by how we can consider those kinds of things as well. So I wonder where that 30-day thing came from.
Yeah, I think the stipulation you're talking about has to do with how quickly you get into a treatment bed, whereas this is once you've been discharged from an inpatient experience, then are we able to keep people supported in the community and avoid a readmission within 30 days? So it does not contradict any of the Supreme Court issues or any of the other legal battles that we're having. It just says that consistent with all medical readmissions, we're trying to keep people from having to go back in the hospital.
Yeah, I'm concerned about the 30-day thing, I understand, but I just don't know where that, if that's clinically based or, behavioral data based.
30 days, there's no magic around 30 days. And actually,
it's arbitrary.
Yeah.
I came ahead. I came ahead.
There's a factor of 30 days. Return it, 30 days.
Well, behavioral.
Yeah, and I mean, I was one of the people who has a lot of energy around this, and I still do, and I think the recommendation makes sense. I think we need to move forward with this kind of a focus, and I'll always feel strongly about that. We have not effectively provided access to mental health treatment in our country commercially, or we've done actually a better job in Medicaid, but not great. And we need to change that. There's federal law, there's a state law, and we need to do that. And unfortunately, on the commercial side, for many young people, their first contact with any formal system is either law enforcement or an inpatient admission. so once they hit that inpatient admission, we need to do everything we can in our power to keep that person and family supported and not be readmitted, because there is lifelong disability attached to every psychotic break that occurs. So that's my emotion about it and the data about it. And so I think the timing issue makes sense. We want it to be credible, but I don't want to see us back off the commitment to go forward.
Susie, Jonathan.
Just real quick, I just want to kind of agree and go forward with the recommendations, and but not give up on the population or the purpose of the measure. I think they're two different things. So if you, even in the MCQA world, whenever there's a new measure, you do get you get a testing time.
Right.
So I think that's really what this is raising, is when we don't know enough, we really need to understand it before we just all jump in. So, but not the side of the no.
To me, the broader question is why isn't there a standard on this? I mean, that speaks to, I think, what you're talking about. It's it's how we think about these illnesses.
Right. There aren't standards on a lot of things that we're interested in. Right. Jonathan.
I support the notion of testing up for 6 to 8 months, but what happens after that could be either a couple things. That you, for the 2016 year, just look at 2015 data, or potentially retrospectively report both the 2014 data that's now going to be tested on for 6 to 8 months in 2015. So instead of starting off with 1 data point, we actually can start off with 2. So I would just say that it's great to get all sorted out, but the data are there. Once it's sorted out, we do better off with having a couple years worth, and that will kind of retrospectively allow this to have been something that we began looking at with 2014 data rather than, simply waiting until the analytics are sorted out and then going forward with new data.
And can I, one comment, some of these measures, it might even make sense to combine 2 years worth of data because of the end.
Yeah.
It might actually make public reporting more possible, so.
Susie, I wonder for both of these, something that might help process later, if you think you have the ability to define sort of what the checklist to push the go button is, so that the group doesn't end up 6 to 8 months from now being in another deliberative process that then we miss another window.
What do you think those criteria ought to be?
Well, I don't know, but I think you've been in it in terms of understanding things around feasibility, the standards we've come up with to bump these up against, endorsement or support by some national. So I just wonder if you had that, then it would be easy for you to come back and say, hey, we've crossed the threshold that we all, that we put forth, we're ready to go.
I mean, Susie, actually, I think you put some of this forward previously in terms of, just the data is available, for example, that there's a big enough end. But I agree with you. I think there are other. I think making explicit some of the considerations, whether or not they're necessarily met or not, because sometimes you might check the no box but have a reason. So one of the things I heard Mary Kay say just earlier was a data steward, and what occurs to me here is who is the data steward? Now, not everything on, as I recall.
The measure steward.
Measure steward. I'm sorry about that. Measure steward. I don't think everything on our list of 52 is NQF endorsed, but there is a measure steward in each case. So, but that would be, I think that would be an example. Yeah. In addition to the, to some of the checklist you've already laid out.
Right. I mean, I would say that there's data available, that there's been an opportunity to participate in vetting the measure. The best I can do is guarantee an opportunity, and whether or not people avail themselves of being involved is not my problem. And that there's an ample opportunity to test the measure. I would say measure steward is a good one. And then the last one I would say is that there's a critical mass of data suppliers that are willing to participate. but I would not rely upon consensus, because I think transparency is a hard topic to rely upon consensus, because one entity can stop you dead in your tracks. So
I think that this kind of iterative approach to these new measures on clinically and community-wide important topics. So it's very easy for me to say, yeah, we need to understand this. I want to know what this is. The data point definition isn't as crisp as when it's gone through an N2F process and there's a steward and all of that kind of stuff. And sometimes the resistance of certain systems comes up with, well, we haven't agreed on all the admit code. What code? It's a very tedious and boring part of the discussion, but it's the part that if we don't get this piece of work done, then we can't even make the report, and then we just look like we're saying no instead of saying, no, just a minute, I don't know what you're asking. And so to do a first, internally, we would do a foray into this by pulling it and seeing what it looked like and going, that's way too big a number, way too small a number. What encounters are we capturing? Have we figured out that this works? And then we do an iteration. And then we'd look at the 30-day readmits based on our data and go, is that good or bad? Or, okay, and then we dive into the next thing. But when it comes in the guise of public reporting, this is like public sausage making here, so some of this, somehow if we could get the cover to do this thing so we are ready for the public reporting because we've gone through the process, that would be great. And I know you can't run that yourself with this timeline, but maybe we need a category of preliminary data and data definition revision within the community to get to more robust and comparable measures.
Right. So I think one of the ways we can give cover, not this year because we would just be focusing on Medicaid, but this was the slide we created before we created the health plan recommendations. So if you just look at the bottom, units of analysis, what I would say is for this particular measure, we want to eventually be able to stratify data by payer type, meaning Medicaid versus commercial, but really reserve judgment for the future about doing data by ACH, county, or individual health plan, and I think it's really because of small n. And that's just something to kind of figure out as we go and have a chance to look at the data. But that not reporting things by individual health plans, for example, is one way to kind of provide that cover and encourage testing.
I think the one thing I would think about, and this you may want to think about this for your meeting with the plan, is thinking about the timeline for it on these measures, because hearing that, there's work that needs to be done to clarify and define these measures, to vet them. There's work that the plans will want to do on their own to take a look at those measures as well. At the same time, you have this body who's very interested in that these are really important measures to have, and we're testing them out with Medicaid. So what I don't want to see happen is that we report out on the Medicaid measures. That's when the work starts at the plan level, so that we're now 2 to 3 years out. Or maybe 2 to 3 years is reasonable, but I think thinking through that a little bit would be helpful.
I just wanted to recognize, we're starting to whittle down a little bit on our starter set. And, we've got this future work of measures that we talked about early on that we can't get to yet. And I think these two are going to be kind of important tests to see, can we navigate through the difficult things that are preventing us from moving forward with this, or a year from now, are we going to be in the same boat saying, we're still not ready, we haven't done the hard work of figuring out how to make these really relevant. So it's a good test, I think, for us to see, can we put the resources into getting the starter set fully implemented, because that's not the end of our role and mission.
It is, but what I would say is that we're not really in the business of measure development. There's a whole sort of science around measure development, and you know, we knew when we picked these measures that, you know, we were taking a chance that they're homegrown. You know, and I don't think that that's a bad thing that we're exploring those things, but I also don't want to create an expectation that this body or that the Alliance or that the Healthcare Authority is going to get into the business of developing its own measures. I think it's important that we continue for as much as possible to look to nationally vetted measures. Because I think for a number of reasons. One is we'll have national benchmarks available to us, but more importantly, it takes a lot of time, resources, money to do it right, to develop a measure and to vet a measure over time. And I just don't know that we've sort of got the bandwidth for that. Scott, did you have something? And then
No, I agree.
Okay.
You know, I would just, the other piece just want us to think about going forward is we're not the only body that's creating a list of measure for business to use. I think what's happening is, in fact, it's more, not less. It's growing every year. So what I would like to, and they're all not the best measures, but more and more, there's more planning and alignment, because we're struggling and suffering from this one, they're not all the same, and it over time becomes burdensome to the point that I don't know if we can make progress. So I would just say that's the world we're living in, and it's not getting easier, just in terms of managing.
So one of the questions, or just even recommendations for this particular measure on the Medicaid side, what considerations are there for the early adopter regions, and how will those consultations be happening with those managed care organizations? Because at some point next year, there's a possibility that the data gets fragmented, and so we just need to make sure that they're prepped and ready for this measure.
So that was very helpful. So then, I guess.
You want a motion?
Yeah, thank you.
What are we moving?
Moving to delay.
Not this.
This one or the?
The one on the handout, yeah. Same thing we did on the oral health.
So there's the motion, the second. Okay, all those in favor? Opposed, same sign. Great.
Great, thank you. So the last topic is the healthcare spending measures, and these are not problematic in the same way that the other ones were. Just to bring you up to date, more of a status report that the Healthcare Authority is on point for developing the detailed measure definition and producing results. There are three, just to refresh your memory. It was the state purchased healthcare spending relative to state GDP, Medicaid spending per enrollee, and PEP spending per enrollee. The Healthcare Authority is beginning this work and assembling an internal team to do the legwork to begin with, but they do plan to seek stakeholder input on measure definitions before we finalize. Again, these metrics are being reported out at a state level and potentially at an ACH level if we can get there. Any questions about this? So that's the status report. Those are the decisions that I needed help with. I thank you for your advice and your decisions. The only thing, just since I still have the clicker, I'll just say that for the next agenda item, I think it's important to select one area for further new work. I'm in support of that. I just want to tell you that not a lot has changed since last summer. So I don't want you to think that a miracle has occurred and there's libraries of new nationally vetted measures on the areas of concern. I still think we need.
There are libraries with new measures, just not on the one.
Not vetted. So just, you know, that's not to say we shouldn't do the due diligence and the work and pick an area and go for it, but I just want to try and calibrate expectations about this work. And with that, I don't know who I'm turning it over.
Yeah, so it's kind of, okay, thanks, and thanks for sort of that set of meetings that led to the 52 measures was actually, in that work there were identified areas that were felt to be worthy of further development, but not a high enough priority to make it into the initial 52 measure set. And as Susie pointed out, part of that in terms of whether or not a particular area was pursued had to do with a recognition that oftentimes there was a lack of a metric that met the criteria that had been laid out in terms of having been vetted and being able to get the data and so forth. There were, I think there were 3 areas in particular that sort of surfaced to the top of that parking lot list. One was, I'm just going to move us along. One had to do with generally with behavioral health and specific measures around depression and screening for substance use disorder. Second had to do with developing a metric or choosing a metric around continuity of care, so care transitions, medication reconciliation, advanced care planning, and the third had to do on functional status. And so what we want to do is sort of engage the group in a conversation. This would be our HCA's recommendation in terms of which ones we might discuss and think about. But we're hoping to get from the group a sense of where we should head next. And today we're not going to be talking about specifics in any of these 3 categories around specific metrics. We're trying to get a sense of the group of which of these general domains should be investigated further, and that would be undertaken by a work group that would be convened really on an ad hoc basis, but include people who were particularly knowledgeable in the domain that gets chosen. So with sure, is there?
Sure.
Oh, okay. So, and Laura's going to give a little more background.
So how we came up with these 3 topics is, if you look at attachment C, you'll see on the second page, what we did is we took the measures currently on the full set of measures, the 52, and we separated them under the prevention, chronic illness, acute care. But then we also took those measure areas or measure topic areas that you all identified last year and that were in our high priority development agenda or the parking lot, and we overlaid them into the current set to look for gaps. So you'll kind of see, and those are the items in red. Those are the ones that were on the priority list that were in Tier 1 and Tier 2. We only looked at Tier 1 and Tier 2 because only those in Tier 3, only 30% of the participants in that survey rated those as high priority. So that's just a little background on how we got to that. And as Dan stated, these are topic areas, not specific measures that we're kind of looking at. But these are in no particular order of preference from the healthcare authority. They're just the 3 that kind of rose to the top for us.
So, yeah.
Well, I just have an immediate response. I mean, they're all important. But my immediate response is number 1. It's just a big population, huge gaps in our ability to do this. That would be across all populations. So not that the other 2. And there are measures available plus, I think Medicare 5-star and MCQA is much. There are other entities that are also probably going to add some measures in that area in the next couple of years. So it seems like that's an opportunity to line, but it's literally a gap.
Thanks. Great.
Yeah, I'm trying to recall the conversations we had 6 months ago, but I think we all are in pretty good agreement that these are important, but the challenge was that there weren't necessarily good measures to use. So it seems to me that our focus shouldn't be on, well, this is what I think is important. It should be more pragmatically on where is there work, where is there new measures and new information we would had before that might allow us to address one.
I think that's a good point. I think Susie's point is there, and that would be part of the work of the group to dig in that way. I think your comment is, at least in the behavioral health category, that there's been a lot of ongoing interest, and perhaps, and I don't know if there's been any new NCQA measures.
There are great NCQA measures now that I believe they're proposing, especially in future depression. So there might be more than there was 6 months ago, but I would not say I'm an expert.
And I don't feel like I can choose between one of these without knowing if there's a measure. So it just feels to me like we should have a decision to have a group or subgroup on some level look and see if there are measures for any of these that we might be able to incorporate, instead of sending a group and having them tell us there's no measure.
Well, I would say these are all really almost clinical assessment, clinical process domains to some degree. And so I'm trying to think of where the data would come from and how hard it would be to extract. On the first one, we have in the state coding for SBIRT. We have a very tiny list of approved SBIRT providers compared to the scope of the population of the problem. I mean, would this be an opportunity to make that better? I know that there's this grant thing that's for training that's out there, but with a really tight timeline this summer. But so I'm just trying to think about, even if we don't have a measure, do we even have a metric, a code that would be able to tell in the course of a clinical interaction if these things have occurred? Because the functional status is, of course, my favorite, but, I don't think we know when that is done.
Right. So I did do some brief homework to take a look at the availability of measures through NQF for these 3 areas. And, it's kind of slim pickings for all 3 of them. So the issue is twofold. Is there a nationally vetted measure? And then secondly, do we have a source of data in the state that enables public reporting, which is different than a source of data to do quality improvement within a single organization? So of the 3, I would say we have a better shot at this on number 1 than we do on number 2 or 3. Yep. But number 1 is not a slam dunk, and I think that our work group process we just have to go into it knowing that we might not be successful this year again. I mean, we looked at this last year, and so, but that's not to say we shouldn't look at it again, because we should. But I just, again, calibrating expectations about what's really out there and what we think we can do.
Well, there might be an opportunity as well, just to anticipate it, just that if you know that there's something or a couple of metrics that are in development, you sort of can begin to move this out of the parking lot without, fully getting out.
I guess that gets at a bigger issue. If we're not going to we as a group are not going to be willing to make measures, but we've identified that there's areas where we're not happy with what we have. Do we have a system in place to be performing surveillance so that we can understand what's coming down the pike? Because for us to act, somebody else has to do some amount of work. And unless we're aware of what's going on out there, we can't say move forward on a given problem.
I think that's,
I'd just like to advocate for a group, and that's the homeless population. There is a group that is collecting data. Substance abuse is certainly on that database. I don't know if we could pull that in, but if we're going to have this metric looked at, we look at that data as well.
The behavioral health, you're talking about behavioral health.
The behavioral health, number 1, is specifically substance abuse.
So one of the things about the intention of pulling this ad hoc group together, whichever topic you guys choose, is to take that deeper dive, to pull some subject matter experts around the table, to really take a little more time to be thoughtful. Susie's right. We looked at this last year, and we just didn't have an answer. And we may still not have an answer at the end of this time frame. But again, I think looking at that, doing the research, find out what's coming down the road, and I can maybe having to wait again until next year. So that's kind of what the intent of this is.
it seems like there's two choices. One is to pick one and pull people together to go in deep, despite the fact that from the people who've looked at it on the surface, you're not going to find what you're looking for. The second, I think the suggestions we made to look across them and have the ad hoc group think about what's coming down the pike on the measurement front and how accessible is the data. And out of that might suggest, based on that finding, which of the subject matter areas makes the most sense. But I'm assuming, you said you looked and not a lot of change, so you can pull a group of experts together, but they're probably going to find the same thing. And you made the statement, we're not in the business of creating measures, which I think is an important definition. So I don't know whether it's looking across the groups and trying to answer the question of feasibility might be a better use of that ad hoc group's time.
I think that's a great suggestion. For the reasons that you bring up. I think sort of doing the look, coming back and saying, of these, this is where we see that there's something possible.
The only downside to that is that it's tough. So, for example, if you pick number one, you could create an ad hoc work group of people with expertise in behavioral health. If we create a work group to look across multiple areas, it's really much more challenging to put together an ad hoc group of experts that have expertise across areas. And I have to give some thought to how I would actually do that. There aren't a ton of measurement experts out there that just sort of know a lot about all those things.
Right. Well, I think this community is fortunate to have a lot of people in the behavioral health field. So we've got a lot of expertise there. I wonder, just thinking out loud here, it seems like functional status is probably a stretch. That we're probably not anywhere near that. But with respect to as much as we would want to be, but with respect to the other two, might it be possible? And taking your point that you want people with expertise, folks who may have participated in NQF, who know who to call around the country, kind of thing. I wonder if, given that the nature of the work is more to surface what's possible as opposed to actually maybe initially agree on or recommend a specific metric, whether it be possible actually to have two work groups with a somewhat modified, where the expectation of the work group is, and I just put that out there from.
So are you a lumper or a splitter? I can't.
Well, yeah, so I'm doing it all here.
Exactly.
I just, and put that out for more discussion as well. I mean, yeah.
I don't know, Susie, if it may be possible to do a little bit of stuff, but if a small expert group to just pose the question about are there any current or future measures or something without going halfway, not too big. That might be possible, but you know best if you work with the technical work group, but that would come up with a measure as opposed to a different question. I don't know.
Right. I mean, it's really to say, is there something here to work with? And if there is, then maybe we can go there. But if not, let's not. So
if we're going to go down the path of let's just take a first little bit halfway deeper dive to see what's feasible, and you do know that you're suggesting yourself for that work because you are one of those experts. What I would say is that we need to just do one work group because that's really how we're being.
Oh, okay, that's fair.
So I guess I would just add on the behavioral health. We have a measure on here under the population measures, and we talked, and you had very nice. I really liked your slide where you talked about the community transformation and the clinical practice transformation, whatever the last group was, our measures on healthcare costs.
I mean, this might be an area, I mean, this is an area from a public health and population health approach where we really struggle with it as well. But it's such a critical measure for us as well, kind of as, you know, the sentinel indicator that raises the flag around how critical behavioral health is. So if we don't get to the clinical side, I am wondering whether there's additional work that we could think of with DSHS and others to look at the population health side. What other measures would be important to track, because we don't have the answer yet on the clinical side?
In alignment with Marguerite's comments, I think one of the things that we're looking at through healthcare reform is how do we truly address things further upstream? How do we get into the prevention end more significantly? And I think number one really opens that door because of the social determinants that lead to that initial depression, the homelessness and that sort of thing. And so from that perspective, I think that's a great candidate to start with, recognizing that all of these at some point need to be addressed.
So, yeah, great.
You know, one of the things that came up earlier are resource issues. So one of the things that would be nice to come out of whatever the work group tackles is not just sort of, you know, what the current state of the art is, but I think giving the organizations that you're going to look to provide this information a heads up, that as you think, because the larger organizations, it's 12, 18, 24 months lead time to do things differently in some cases. So looking at some of what's coming, you know, to the degree there's an interest in one of these areas, giving people who think about those things in their organizations a heads up that now is the time to start thinking about resources so that some of this information, when we're ready for it. But I think there's a big difference between creating a measure and doing work on your underlying data infrastructure so you can produce the information once the measurement gurus have done their work. And that's where the lead time and resource constraints are. Because I would hope however these groups get tasked, part of it is not just what is, but to give feedback back to the community about what might be coming along prioritization.
I think that's a great point. I mean, and it just, you know, it sort of fits with the idea that there probably are some measures that are in development here, and it's sort of the notion of a longer runway, and what do you do with that time in anticipation so that you can really hit the ground running when there's a validated metric. John?
So this may be piling on the first behavioral health one, but given that there's such an emphasis on behavioral health integration in the state innovation model MMI grant, it seems like that's both an opportunity to do what Rick is talking about, you know, whatever happens with structures, now is the time to think about kind of the data systems that might support delivery of data for a measure soon to be, yet to be developed. But it just seems like there's enough kind of, if the choice is one of the three, that would seem to be an additional consideration that would push you towards number one. That the state has now a whole bunch of money, resources, and time focused on behavioral health integration activities that will result potentially in development of new structures, data systems, and other things. And, you know, to telegraph, we're going to be looking for something in that domain would probably be another stimulus to the ability to get some good data at some point.
I just point out, I mean, there's sort of two ways to approach this that have been put on the table. One is to pick one and form an expert group around that. The other was to create a work group to look across areas and figure out what's feasible. And I would just say almost all the comments that have been made in support of behavioral health. So it's just an observation. And I think that if we go that route of really just picking behavioral health and figuring out what's feasible either at the population level or the clinical level, we are in the time frame that we have, we are likely to come up with a sort of a more solid answer than the other approach. Yeah.
Can I throw out a third option, which would be no working group, but just a kind of a horizon scan, and when some of these emerge that look like they're ready or getting ready for prime time, then the working group gets established. I'm just afraid you're going to have a working group with no measures that aren't ready or even close to ready. It's a matter of people's time and resources.
I like that idea, except that as much as I'd like to think I'm an expert on everything, I have to come to the realization that I'm not. And a work group would be helpful, both from the behavioral health community to help understand the meat of the topic, but also from the data supplier perspective of understanding what's really possible and what's not possible, both from DSHS, the Healthcare Authority, and the commercial health plans. That I feel like that I would, for example, being the person who's going to run this work group, is that I need some help to figure that stuff out, to answer those questions of scanning the horizon from a knowledgeable standpoint.
And I think we do need to more aggressively lean forward on this front.
Say it one more time.
Aggressively lean forward and, scan, figure out, what data variables are going to need to be collected and really push to have those collected. And I'm afraid if we don't form like a solid work group, it won't.
Yeah.
We'll be aggressive.
Dale Reiser's on the phone and apparently can't, just had a comment which is that WFMA has a behavioral health work group that would be a good resource for number one. And actually, I happen to know that because I met with them just last week, and it really is sort of some of the best experts in behavioral health from around the state that participate in that. So, and you had a comment.
Well, I was just going to say, I think the fact that it's difficult to find the measures reflects, again, the history, and there are many measures. They just don't happen to be NQF or NCQA because behavioral health has not been on the radar screen. There are many nationally vetted scales and tests and measures, and I think that there is something there that's doable, that's some of which is already being used in a variety of settings in our own state. So it doesn't reach the same standard as the other kinds of measures we've been talking about, but I think there's a place to start, and it's part of what system integration means in addition to, what the SIM grant is trying to do. It's how the whole environment around us has evolved to make this challenge sort of solidified, and we're trying to break that all down. So I think there are tools that can be found, and we have to look in places like NIMH and SAMHSA and the National Council for Behavioral Health. There are national research-based tools that we could at least start with.
I guess I would just say that, given that to think about tying the last conversation, the one around psychiatric inpatient readmissions, to what we're talking about for behavioral health. Because I think that if you can create a work group, and because it's so important that the plans are engaged in this, that's a nice opportunity to kind of have a conversation that continues to flow.
I just want to add to what Ann said, that there are lots of measures that we can discover at the local, national level. But I think everything that we can do, anything we can do to start promoting a real serious look at our mental health, what I call a mental illness system. It's not a mental health system, it's a mental illness system. And it's really sad to me when a national study shows that the state of Washington is 47th in the nation in terms of need for health care, mental health services related to access to health care services. We're practically on the bottom of the country. And I think anything we can do to stimulate a careful look and introspection on what it is that we're doing, we're not doing in the mental health area, the behavioral health area, is going to pay huge dividends as we go forward.
So we kind of skipped over this slide, but I think it's just important to mention that I think as we engage in this work, we really want to follow the same kinds of criteria that we used last year, which is it doesn't have to be NQF endorsed, not all of them are, but it should be a nationally vetted measure with a measure steward and with measure specifications. It needs to be be measured with readily available data. There's no point in creating a measure that we have no ability to, or agreeing to a measure that we can't measure because we don't have a way to do it. And then finally, that we want to pick things that reflect areas of health and healthcare that are thought to have a significant impact, and that there's that impacts a big enough part of the population that it supports public reporting on a statewide level. So it's not just coming up with measures; it's also having a sufficient N and a source of data that enables this work.
Craig.
So, respecting all the enthusiasm around focusing on behavioral health, which I have no problem with, we're presumably going to go through this again in some period of time and try to pick the next topic. It would be very, very valuable for the group to be provided with information on what's going through NQF or other national vetting organizations, what's in their pipeline, what they can share with us so that we have an idea of what might have changed in the landscape of available sort of nationally vetted measures to guide our decision making.
It's all the whole arc of the measure development and list is on their website, so we can.
Okay.
What your point's all taken. And
yeah, I was just going to say that we may find that we do this work and it simply cannot be done the way that we need to do it, and that may generate a different kind of recommendation. I think we need to be practical about the state of the art, and we need to not lose the intention of looking in that focus area. So I kind of see both. I see both realities. I just don't want to back off because we may not achieve the standard that we want.
Yeah, sort of following what we've done today, I would offer a motion that we support the creation of a work group that works on item number 1.
okay, so it's on the table in a second, but before we vote, actually what I'd like to do is take public comments. So,
sure.
I think before we actually have a decision. So I think first I'll turn to folks here in the room and ask if there is any public comments on. Okay, and then can we? Is it possible for? Is there any public comment on the phone? Megan, do we?
This topic or questions in general?
This topic.
This topic, yeah.
Okay.
So there's nothing on that. Okay, so there's a motion on the table to move forward with a work group on number 1 in behavioral health, and so it's been seconded, and all those in favor, aye. Aye. Opposed, same sign. Okay, all right. So we're gonna move forward with that, and then I guess we should ask for any other
questions?
Any other
questions earlier?
Does NCQA do audits of health plan data? So,
yeah.
All right, and
maybe though this is maybe you guys should respond to this a little
right,
bit because I think
right.
this is an educational
Right,
question
okay,
versus
yeah.
post on the phone.
There is no process required for anyone submitting to NCQA has to have an auditor looking at the process. It's required, it's part of the process.
Yeah, there's a pre-submission audit occurs, and most organizations, as a best practice, do interval audits to ensure that when submission comes, they already know what the audit will look like. So there's extensive audit trails related to NCQA data submission.
Which is the reason to rely upon the results submitted to NCQA, because we can't replicate that in any way. Here in Washington, there's already a national process for that, and it makes sense to rely upon it.
And they have back to my earlier point, they have very strict definitions of all aspects of the data points, including one thing that actually is going to be hard for us to make these useful to us in the community, which is continuous enrollment requirements for denominator inclusion.
Yeah.
And so so that makes it hard for us to determine is something that we are instituting this year having an impact on certain metrics without some kind of longer wait. But, but it's very precise and very scrutinized.
Right. There actually is I think a second part to this question, which I'm not sure I understand.
I think it's separate.
Or is it how are community health centers represented?
Yeah, how are
in
community health centers represented, I think, in all of this. So this came in really early.
Yes, that's my job. This is Dr. Bucknam, so whoever asked it. Any other thoughts or questions, just come see me.
I'm sorry, could you say that one more time? The question was, how are community health centers represented?
And Patrick, maybe you could just say where you're from and your name.
So Patrick Bucknam, I'm the CEO of Columbia Valley Community Health. I'm also the chair for the board of the Washington Association of Community Migrant Health Centers.
Thanks. And I think that's all we have.
Were there any other questions?
Public comment. We're back to you, Nancy.
Okay, so here we are, way ahead of time, and I think before we do the wrap-up, I mean, there was a very good suggestion made about developing a system for scanning the environment about new measures that are coming down the pike. Are there other comments or suggestions that would strengthen our work?
Did we vote on the measures?
There we go. We suspended the vote for public comment.
No, we did it. I came back and we voted.
We did. Did you miss that? I missed it too, I think.
You voted aye.
Okay, so we're back to opportunities to do additional homework or improve. So, Rick?
I guess I have a question. So much of this is claims-based, and barring another seven-word change in Congress, ICD-10 will go into effect October 1st. And the survey we did, and I think it tracks with other surveys that have been done, would indicate that the world will not come to an end and people will get paid. But there are lots of concerns about the level of training in documentation on the provider side of this. So it would be reasonable to assume that along with that change will come some crappy data. And so I'm just wondering if there is any, for all of you who have to worry about that, if there is any type of process to, do extra auditing, to try and anticipate that, to do surveys, because there's a reasonable expectation that, this core data we're all depending on is going to have some reasonable expectation of quality issues.
Yep.
After October 1st. So I don't know the answer to that, but I think it's going to be a big issue.
Yep.
I agree.
Do you guys want to comment? Mary Kay at all? You agreeing?
Well, so my detailed knowledge of this isn't, I've tried to avoid detailed knowledge of this, but anyway, so I know the deadline's coming, and I know some large pieces of analysis which say only 70% of ICD-9 or ICD-10 coding maps up current ICD-9 coding. So it's essentially a different approach to data. And so it's not just like we tweaked it. And it's a complex data system in a complex world of healthcare. So I don't suppose anybody, unless somebody's done some pretty remarkable modeling, knows how this is going to run. Then we have all the technical aspects of systems, and we have, we are in a crossover starting the first, I think, of being able to receive claims with either system. So we might start getting the data of where they're going to skew. Yeah. We have training issues. We have, billing offices and small practices. We have clearinghouses. We have claims software platforms. We have all of which present problems in and of themselves today. And all of this is going to be run through this massive change. So I don't know what kind of analysis I just gave you, but what I'm saying is that I don't think people are sitting on knowledge that this is going to happen when the transition occurs. I think we don't know about a lot of it. And then I have not seen an analysis of this thing that we hear about the 30% discrepancy of crossover, if that's in a obscure codes or common codes, maybe the true functional discrepancy is 2%. But I have never seen that analysis.
But you're endorsing the comment that this.
We hold onto your hat.
Okay.
Rick, I would add on to a little bit to endorse everything Mary Kay just said, but I think there are a couple of hanging chads out there right now. We don't know exactly what CMS is going to do. Will they require a hard flip to ICD-10, or will they allow a phase-in period? That is a huge determinant of how the whole market moves. So that they still have not gone out on what their policy decision is regarding that. And that could severely disrupt or accelerate the rate of conversion. So that's one thing. I think as a theme, as with most things, and I think the work of this group is trying to address it, though at times as we rush to try to add more measures, I wonder, complexity continues to grow in healthcare. And ICD-10 amplifies the complexity tenfold because there are 10 times the number of diagnostic codes for ICD-10 as there are for ICD-9. That's more complex. We're adding another set of measures that's more complex. That burden just continues to grow, which makes it harder for folks to do quality work, period. So I think it's an astute point. We have been doing testing of data interfaces with large delivery systems, and that seems to be going smoothly for some of them who've been planning. So I'm encouraged by that. Mary Kay's point, though, that the delivery system is a multifaceted entity indicates probably the majority of providers, maybe not by overall practitioners, but the majority of provider entities will be underprepared and will undermine the integrity of data, which has vast implications for how the state pays MCOs, how Medicare pays health plans, and how we all look at how we try to measure success in a value-based purchasing world, which is largely including some form of risk adjustment as a base. A lot of that we're going to just be uncertain. And so the good news is I think most of us are aware of that and are just going to put on our seatbelts and go through it.
Yeah, but I think your last point is the key, because the worry has been when we get paid. The worry has been will claims come in and we get paid. Probably that will be okay for most people. But the last point is the system moves as the measurement value becomes so much more important because of the nature of the reimbursement, and in the short term it's going to be claims driven. That's going to be a huge issue. And I don't think my suggestion was not that we try to solve the problem this morning. It's that if you're looking, we know the answer, right? Yeah. But my suggestion was because this is so driven by claims data, that rather than wait for the train wreck, it might be worth, if you're talking about putting groups together or doing some study, sometime in the near future convene a group of people who thought about some of those things and at least begin to have some heads up. Maybe you want to do some testing. I don't know what the answer is, but I think to wait and just not deal with it could have huge implications. They're going to be much tougher after the fact.
Good comment. Thank you. Jonathan?
So this is even a longer term complication here, but one thing that's occurred since this committee last met was the famous SGR bill passed, the sustainable growth rate thing, but it was replaced by a new bill called macro, which is going to have a profound impact, not yet, people haven't quite sorted it out, but on the way actually people get paid, particularly physicians and other providers. It's not going to have any impact in the very near term, probably not until like 2019, but there are going to be a whole bunch of other kind of quality metrics that are going to be incorporated into, at least the goal is to incorporate it into a substantial proportion of Medicare payments. And there are going to be ways beyond actually administrative data, claims data, that are going to be incorporated in that. So for instance, there are provisions where practitioners, both facilities and individual physicians report to, quote, qualified clinical data registries, which are going to be another way to kind of get the brownie sorted out, there are also going to be substantial changes in the way performance measures are going to be reported to CMS. That's going to create both some challenges and some opportunities for groups like this that are trying to look at some performance-related metrics. And so at some point at a future meeting, it might be nice to even have some kind of education about what's in the future. So to kind of get prepared for a couple years from now on how the measurement landscape will change, we maybe even start thinking about either clinical topics or ways of collecting data that are very different than they currently are. Now, a lot of the dilemmas that we're facing about what you can get out of claims data, there's going to be kind of an alternative pathway to get clinical data that will inform some of the measures, including in some of the areas that we've had difficulty now.
I had the same comment, and I was just wondering how this work group, the work in this work group is intersecting with the clinical data repository work that's going on at HCA. Because, I mean, at some point you need to start thinking about what variables, you know, you want to collect and what's going to be put in the data, in the clinical data repository, which is very closely linked to potential future performance measures.
I don't know if you want to.
Well, I think, you know, part of what we talked about earlier was sort of the timeline, so readily available today. So you're not going to have a critical mass of this information readily available today. And just as the industry has suffered a lot of pain figuring out how to use claims data, it's going to suffer a lot of pain figuring out how to use these standardized clinical data items. So it isn't, and you know, some of the comments Jonathan made about the emergence of registry/repositories, I think that's going to be a growing phenomenon. So again, I think the question is, do you want to have a future-looking activity that anticipates some of those things? It is not a tomorrow activity, but you know, it takes a lot. We all learn it takes so much time in healthcare to get things done. That as people, you know, starting to think now. So if on those three areas, claims data doesn't necessarily meet the test, and we're going to need more clinical. And as people are thinking about priorities and so on, maybe beginning to have some of that conversation at an earlier point rather than a later point, mixing in some of the things Jonathan talked about, because when CMS starts prioritizing things, that's going to trickle through everybody's priority. So again, it's a question of whether you want to convene some further looking activity either in parallel or after you go through this activity we just talked about.
Great. Other comments?
The question about the frequency of generating the data for these measures after the initial data set comes together.
You know, it's going to change over time. I think our next goal will try and get to twice a year with the all-payer claims database. Once that's put in place, there's an opportunity to go quarterly with more frequent data feeds. But it's, you know, it's hard to do it very often because of the significant validation processes that have to be run against the data. And that's all, some of which is spelled out in the ABCD legislation, some of which is just good practice, where you involve your data supply, you aggregate the data, you run the measures, you give people an opportunity, both first data suppliers and then providers, to look at the results and validate them. And all of that just takes time. So, you know, I think our goal is to certainly do it much more frequently than once a year, but I think it's going to be tough to ever get to anything better than quarterly, and that's a stretch.
Okay, great discussion. The wrap up here is there'll be a summary in today's discussion on the HCA website in a week. Our next meeting we think is likely in October, and we'll accept